just to show you. Okay. Just to show you, I mean, not very nice takeoff of the circumflex. Maybe this was not the best view. And it was in 1-1-1 bifurcation. Honestly, I discussed with our team because the patient was stable and they turned off the patient despite it was 50, because the idea was to wait the neurological status because the patient arrived clearly intubated after cardiac arrest, but they declined. And since it started to be hemodynamically not stable on the CALAB, I proceeded to PCI. I inserted an Impella before starting because this was 3-vessel disease, LVF 30%, young patient. For me, this is Impella indication, as we will discuss later on. And I already showed to you. So first thing, Impella on, and this is the end. I'm not going through all the procedure. There was a very long procedure because what I did was to do a decay crash on the left main, and to where first left main circumflex, then left main Alaide, and then to complete all the Alaide, you know, till this point, with just keep it open approach on the diagonals. The procedure was done with Impella support, as I said, and with IVUS imaging. And today we are going to finish and stage also the right. The patient recovered, now is awake. LVF is improving, but clearly it will take time. But just to show you, unfortunately, what happened, I mean, last week and why I could not join. And I think it's a great example for me of indication on Impella. Then, what are we discussing today? We are discussing today the expert consensus document. It was a joint effort from European Association Percutanoues Coronary Intervention and Acute Care Association within ESC. This was a joint document, and so it was simultaneously published on Eurointervention, which is the official journal of the APCI, and indeed the European Journal of Acute Cardiovascular Care, which is the official journal of ACVC group. Why that? Because, I mean, you are having the same phenomenon, but in Europe, we have been seeing an increasing in usage of mechanical circulatory support. But however, there is, as we know, no randomized clinical trial that is demonstrating the advantage of usage of these devices. I mean, there are randomized clinical trials on intra-aortic balloon pump that in reality did not indicate intra-aortic balloon pump for the use in cardiogenic shock, and also does not indicate in high-risk PCI because the trials were all negative. Indeed, for the Impella, still are pending an ongoing randomized clinical trial. So what we have for Impella is the evidence coming from large registry, if they are, and some equivocal and very debatable data coming, especially from US, from your insurance company registries. But the point is that despite all that, we have been observing an increasing use, and therefore the two scientific groups within ESC thought to put together the effort in order to go through the usage of these devices and to look each single possible indication and give not recommendation, because recommendation you can give only within guidelines, but you can give at least indication of use, exactly what they did. Another interesting point of information is, despite what we said, that the only evidence that we have is that intra-aortic balloon pump is not indicated and it's not recommended by guidelines in cardiogenic shock or high-risk PCI. Despite this, as you can see from the right, and that publication, still intra-aortic balloon pump is the most used MCS support in our CALAB. And this is one of the figures coming from the document that put together the different devices. just to underline that MCS is a concept very heterogeneous, because the device that we have in our handles are completely different. So starting with the left ventricular support, we are talking about intra-aortic balloon pump, which gives a pulsatile type of flow, but give only a flow 0.5 liters. And this is very important, and explain why in the setting of cardiogenic shock, intra-aortic balloon pump failed to demonstrate superiority versus standard of care. So no intra-aortic balloon pump, no MCS. This because the flow is really limited, 0.5 liter. Insertion femoral artery, cannula size, that's the good part of the intra-aortic balloon pump, because you can have intra-aortic balloon pump also 7 French compatible. Regarding then the coronary perfusion, there is it is been described an increase also in the coronary flow, but again, there are no data, randomized data in support of this. Then you have Impella, and Impella family is going from a 2.5 CP, 5.0, 5.5. This is a continuous axial pump, and the flow is between 2.5 and 5.5. As you know, 2.5 is the 2.5 device. CP is going to give up to 4, and then you have the 5.0 up to 5, 5.5, which is the newcomer, up to 5.5. So you have different devices that you can use in the different indication. Insertion can be by femoral or subclavian artery, and the cannula size depends on the device you are using, from 12 French and then 13 French for the CP, up to 21 French for the 5.5. So you are going from a completely percutaneous femoral approach to indeed a surgical cut down in the case of 5.0, 5.5, or more recently, some groups developed also a fully percutaneous transaxillary approach for 5.0, 5.5, which is honestly what we are doing in my hospital. Having said that, in this case, you are going to act toward having a left ventricular unloading with Impella, and other competitors are tandem heart, which has a type of flow continuous and centrifugal, and is going to provide a maximum flow of 4.0. This is femoral vein and femoral artery. And again, the cannula size from 12 to 19 in the arterial and 21 French in the venous. And then there is the IVAC 2L pulsatile. It's going to give 40 milliliter per beat, femoral artery 17 French. This is for the left. For the right, indeed, you have Impella RP and tandem heart RV Protect Duo. Impella RP again is going to give you a continuous axial flow, maximum of 4.0 liter, insertion through vein, femoral vein, 22 French. And then indeed the tandem heart RV and Protect Duo give you a type of flow continuous and centrifugal, max flow of 4.0 liter. Femoral vein, internal jugular vein are the possibility of the access, and cannula size from 21 to 29 French. And then for biventricular support, you can use via ECMO, that indeed has a continuous centrifugal type of flow maximum to 7 liter. And you can know you must have an insertion in femoral vein and femoral artery. The cannula size for arterial is from 14 to 19, and for the venous 17 to 21 French. The only problem of the ECMO is the fact that is going to increase the resistance, and therefore when you are using an ECMO, you have to think to couple the ECMO if you have, for example, a cardiogenic shock in the context of ST elevation MI with another device that can act with the unloading during ECMO support. That can be an Impella, or there are centers also using IABP. In this case, there is then ECPella if you use ECMO together with Impella. And for biventricular support, you can also use left and right Impella. That's another possibility. So this just to show you that actually we are talking about different devices. And also in these slides taken from the manuscript, the consensus document, you see how the mechanism of action of the different options are different, and which is the kind of action they're going to take. Then the document went discussing the different kind of indication. Again, this is an expert consensus, cannot give recommendation, but can give indication. In the meantime, just for the knowledge of you, that if you didn't look at that, it has been published indeed the guidelines from the European Society of Cardiology for chronic heart failure and acute heart failure, and but nothing regarding high-risk PCI. In case of high-risk PCI, where the writing group defined as high-risk PCI the presence of one clinical characteristics together with one angiographic characteristics, and the characteristics that were evaluated were LVF less than 30%, hemodynamical instability, severe diabetes, acute coronary syndromes, previous cardiac surgery, and chronic kidney disease. One of these characteristics, together with an angiographic characteristic such as very diffuse and multivessel coronary artery disease that clearly required multivessel revascularization, unprotected left main involving bifurcation, severe coronary total occlusion, where severe coronary total occlusion was intended as a complex total occlusion, rotational atherectomy, and last patent conduit. So in case there were the presence of one clinical and one angiographically, which are the MCS that are indicated? Intra-aortic balloon pump, according to the evidence coming from the randomized clinical trial BCIS1, should not be used, because in that trial, intra-aortic balloon pump was used in high-risk PCI and did not demonstrate superiority as compared with standard of care without any support. Indeed, axial flow pumps such as Impella may be considered in highly selected patients undergoing high-risk PCI in case of acceptable femoral access more than 6 mm diameter of the common femoral artery and no severe tortuosity. Where it comes the evidence? Evidence comes from the randomized clinical trial PROTECT 2. As you probably know, that trial failed the primary endpoint at 30 days, but indeed showed a positive signal for the use of Impella in 90 days. And cohort studies, because we have registries, and by the way, we published the Italian registry of Impella, which is called IMPIT, where the usage of Impella in high-risk PCI demonstrated very encouraging results. Via ECMO, indeed, should not be used in the context of high-risk PCI because there are no data available. So the suggestion from the group is not to indicate in case of high-risk PCI, and we are talking about elective patient, via the usage of via ECMO. High-risk acute MI was another indication that was discussed. We are talking about high-risk acute MI without cardiogenic shock. In this case, intra-aortic balloon pump should not be used. The evidence again comes from the randomized trial CRISP-AMI and PAMI2 that again did not show the benefit of intra-aortic balloon pump in this indication. Regarding indeed the axial flow pump as Impella, Impella CPU seems feasible as a preventive unloading strategy. However, and this is based from preclinical studies and pilot trial from DTU that was published by Naveen Kapoor a couple of years ago on circulation, that showed that an unloading with Impella CP in large ST elevation MI without cardiogenic shock was feasible and safe. Currently, it is ongoing indeed, as you know, the D2 trial that is randomizing this kind of patient with unloading of 30 minutes before primary PCI without primary versus primary PCI. But the study is ongoing and we don't have the result clearly yet, and we will not have since I think a couple of years, because as far as I know, only 80 patients have been enrolled in the study that also now is extending in Europe, already starting in Germany and soon starting in Italy. So there are no randomized clinical trials demonstrating the advantage of the usage of Impella in high-risk acute MI without cardiogenic shock, but however, its use seems to be feasible and safe according to the data from the pilot study. Regarding indeed the use of VIA ECMO in this indication, it should not be used also because there is an increasing afterload in the setting of acute coronary ischemia, and this might be harmful. And in fact, any evidence regarding the usage of VIA ECMO in high-risk acute MI without cardiogenic shock are not available. There is no study. This is why it's not indicated. In the document were reported and used also the classification coming from SKY that I think you are all familiar with, going from A to E, where A are the stage at risk, so the patient who is not currently experiencing signs or symptoms of cardiogenic shock, but is at risk for its development. This patient may include those with acute myocardial infarction or acute or acute or chronic heart failure symptoms. Then B is the beginning of cardiogenic shock. Patient who has a clinical evidence of relative hypotension or tachycardia without hyperfusion. C, as you know, is stage C is classic cardiogenic shock, patient with hypoperfusion that requires an intervention with drugs or mechanical support beyond volume resuscitation, restored perfusion. This patient typically presents with relative hypotension, this deteriorating shock, getting worse than category C, and they have failure to respond to initial intervention. Then there is the extreme shock, a patient with circulatory collapse in refractory cardiac arrest with ongoing CPR or being supported by multiple simultaneous acute intervention, including ECMO, facilitated CPR. These are patients with multiple clinicians at the bedside laboring to address the multiple simultaneous issues related to the lack of clinical stability of the patient. So taking into account the classification from SKY of cardiogenic shock, in our document, the indication was given to deteriorating shock, SKY, C and D, failure to respond to initial therapy, and consider mechanical support if there are clinical signs of relative hypoperfusion, and then sign of left ventricular failure as one of the following: systolic blood pressure less or equal to 90, or mean arterial pressure less than 60, or more than 30 millimeter of mercury of drop and inotropes or vasopressor, cardiac index less than 2.2 liter minutes per square meter, or cardiac power output less than 0.6 watts, or, and this is the most used, at least in McCalab, a left ventricular and diastolic pressure more than 15. Indeed, consider the usage of the devices for right ventricular failure if central venous pressure is more than or equal to 15, pulmonary arterial pulsatility index less or equal to 1.85, and right atrial to pulmonary capillary wedge pressure ratio more or equal or 0.8. And then which are the indications for PVAD, for the different PVADs in cardiogenic shock? Intra-aortic balloon pump again is not recommended routinely. It may be used in patients with mechanical complication post-acute MI or in non-acute MI related shock. This is coming from the IABP Shock 2 trial that, as you probably know, was a negative trial. So in this trial, IABP did not demonstrate any benefit toward standard of care in the setting of cardiogenic shock. Indeed, Impella, CP may be used as a short-term therapy in cardiogenic shock, stage C and D, as we discussed in the prior slide, with potentially reversible underlying cause or indication to transplant, or in patients that are candidates to VAD. And this is important because also all these, if the device is a bridge to another treatment or a bridge to transplantation or to VAD, has been discussed in the new ESC guidelines on acute and chronic heart failure. And in fact, this was also discussed in our document that came before then the new guidelines. Which is the evidence? The evidence comes from small randomized study, that is PROTECT 1 and cohort studies. But however, it is ongoing, the danger shock trial that is conducted in Europe and is evaluating the usage of Impella and cardiogenic shock versus standard of care. Finally, the VIA ECMO. VIA ECMO in the setting of cardiogenic shock may be used as a short-term therapy in cardiogenic shock stage C, D, and E, particularly in patients with combined respiratory insufficiency with potentially reversible underlying cause, again, bridge to transplantation or to VAD. And this is coming from prospective and retrospective cohort studies, and then VIA ECMO may be also used for selected patients in refractory cardiac arrest. Having said that, as I already mentioned before, if you're using a VIA ECMO in a cardiogenic shock stage C, D, and E in a patient having an acute MI, you have to consider that because VIA ECMO is increasing the resistance, it's important to decrease the afterload to unload the ventricle, and so to couple the VIA ECMO with Impella, doing an Impella, or in case this is not available, or there is also the experience of some center in this context, to have VIA ECMO together with the intra-aortic balloon pump. Again, with the aim to unload the ventricle whose afterload is increased by the use of VIA ECMO. In the document has been discussed also the weaning from PVAD, and this section was written by Susanna Price as the chair of the ACDC group. And I think they give a very nice flow chart. For the weaning from PVAD, you have to evaluate the reaction of the patient of low-dose vasopressor and inotrope, the value of lactate, the PCWP, and the presence or not of congestion. Because if there is a stable low-dose vasopressor or inotrope, P lactate is less than 2, pH is more than 7.35, PCWP is less than 15, and there is no congestion. If no, clearly you have to wait other 24 hours. If yes, look to the rhythm of the patient. If the patient is in sinus rhythm or chronic atrial fibrillation, well controlled regarding the rate of the atrial fibrillation, and the echo exclude mechanical complication and significant valve insufficiency, you can then reduce the PVAD to half power for 4 and 8 hours. And again, relook to the P lactate, oxygen demand, uresis, and pressure. If they are unchanged, further reduce the MCS to 1/4 of the power for other 4 and 8 hours. Again, recheck after this timeline P lactate, oxygen demand, uresis, and pressure. And if they are unchanged, you can finally remove the PVAD. If all the different steps are not met, in the first 24 hours, you wait. But if after that 24 hours, the patient is still not stable, according to the parameter we have discussed, you have to consider the upscaling of MCS. And this was an important concept that came out in the document. You don't have to wait too much to think of upscaling your MCS. But when you don't get the stability or improvement of the patient, after 24 hours, you have to think eventually to upscale. Complication was another important section, because we have said about the potentiality and improvement expected by the usage of PVAD, but however, these are devices that are not excluded from complication. We just published in European Heart Journal Acute Care the device-related complication from the Italian registry of Impella. And actually, this is in line of what was written in this document, because you have to look for complication. Clearly, complications are different according to the different timing and according to the different devices. Implantation-related complication can be bleeding, vessel perforation, embolism, tamponade, valvular lesion. You have to look to the SIRS, the presence of an inflammatory reaction due to the usage of the devices, infection-related complications that clearly are going to be higher as the time passes by, acute kidney injury that can be higher at the beginning of the implantation of the device, also because if there are patients that also underwent PCI and, for example, they were in cardiogenic shock, the risk of acute kidney injury is higher. And there are some evidence that, for example, the usage of Impella is improving also the occurrence of acute kidney injury. An access-related complication that can happen immediately after the insertion, but also if you have the Impella in for a long and prolonged time, can also occur later in days. Circulatory complication and bleeding and thrombotic-related complication, especially with the usage of ECMO, as well as ICU-related complication, critical illness, neuropathy, myopathy, and delirium. So this is just an alert to look for the complication that can be device-related complication, can be more frequent with some of the devices and occur also in a timely fashion. Ongoing trials, as we said, we are still lacking evidence, especially for Impella. So what is ongoing? Ongoing is the danger shock that I mentioned. It is including 360 acute MI complicated with cardiogenic shock in Denmark and Germany. And the randomization is Impella CP versus guideline-directed therapy. And the primary endpoint will be 6-month mortality. But however, the study is ongoing since 10 years. So the time of enrollment has been extremely long. And unfortunately, the PI of the study just said in a meeting that I was in last week that they expect another year to complete the final enrollment. So we will have more than a 10 years trial, and clearly, most probably, this study should be then analyzed according to the different timelines, because as you can expect, this device improved throughout the times, and it would be difficult to really compare patients that were treated in 2012 at the beginning of the enrollment and patients that indeed were treated in 2020 or 2021. Then ongoing is STEMI-DTU trial. The STEMI-DTU trial is indeed included 688 patients with anterior ST elevation MI without cardiogenic shock, started in US, now rolling in Germany and soon starting in Italy. The randomization is 30 minutes of unloading with Impella CP, then revascularization, reperfusion versus indeed PCI, primary PCI according to current guidelines. The endpoint in this is MRI related, is infarct size at 3 and 5 days measured at cardiac MRI. Then there is the AeroShock. Again, patient with acute MI complicated with cardiogenic shock, 428 patients, randomized to ECMO versus medical therapy, endpoint 30-day mortality. ECMO CS, it's another trial, very small one, with a cumulative endpoint, again, randomizing ECMO versus medical therapy. Anchor is indeed randomized ECMO plus intra-aortic balloon pump for the concept that we said of unloading, again, an acute MI cardiogenic shock versus standard of care. And other ECMO trial is ECLS shock, randomizing indeed ECMO versus medical therapy. Intra-aortic balloon preview is a pre-PCI intra-aortic balloon pump versus no intra-aortic balloon pump in the context of acute MI CS. And then there is the reverse, ECMO alone versus ECMO plus Impella in cardiogenic shock, as well as Pulse study, very small trial, indeed evaluating EVA C12 versus Impella. Having said that, the group identified gaps in knowledge and need for future studies. What we identified is the need for pathophysiological study evaluating ventricular unloading in high-risk myocardial infarction and cardiogenic shock, randomized clinical trial demonstrating the benefit of PVAD over standard of care in high-risk PCI and CS. As you know, it started also the randomization of the P4, that indeed is a trial randomizing high-risk PCI with standard of care versus Impella. And randomized clinical trial demonstrated benefit parallel shift from door to balloon to door to unload, which is the DTU, need for large prospective national and international registry evaluating the outcome of PVAD in a real-world population. And soon we will start the PROTECT EU registry, that is Italy plus Germany, and we will analyze high-risk PCI using Impella. But there is also need for algorithm and protocol to better define patient population and timing for PVAD, which is another point, when to implant the PVAD. The group of experts actually came out with the indication of implanting before the procedure. So when there is an indication, the indication is to implant the PVAD before the PCI. And then last but not least, the need for protocol and proper education of physician and all healthcare providers in order to reduce device-related complication. So thanks for your attention, and in this slide there are all my contacts from the email, from the Twitter and Instagram, if you want then to contact me after, I hope, the discussion that we are going to start soon.
Thanks so much, Dr. Chieffo. That was a wonderful talk. I'm going to open up the forum for questions. I think Samit here has a question in the chat box. Says, thank you for a great overview. We see patients referred from a number of medical centers. How can we standardize our evaluation of cardiogenic shock, starting with ER triage?
I mean, is what I said. I mean, in the document, what we are evaluating is first the stage of shock. There are two main evaluations that you can do. You can use the SKY classification. And so mostly you are going to implant the Impella, for example, in CAD patient and evaluate if to, and from D and E, the ECMO. According to indication that we said, and then you have to evaluate something that I did not discuss, which is the intermax level. And according to the intermax, there is, I'm talking about the cardiogenic shock, the indication or not to the device. My personal thought is what is also popular in US, that I don't think all the centers should be managing this patient. I do believe in a protocol and center dedicated to cardiogenic shock. So my feeling and my idea is that you should have, as we have hubs for primary PCI, you should have hub for cardiogenic shock, because cardiogenic shock is not only the disease in the car lab. By the way, in the car lab, we have just the minimal problem. The problem is how you are going to manage this patient after, because the Impella is not going to be removed immediately after, or the ECMO. The patient has to be managed by intensivist. And so you must have a capability in the hospital to properly treat this patient, as you said, identify who is going to need support and which support to be done, the PCI if this is ischemic related, and then to be properly followed up in intensive unit care with the physician that know the devices and know how to manage and overlook them. And by the way, as you know, center in US that were using this kind of networks, such as all the Detroit experience, showed that when you use protocol for cardiogenic shock and you have the right network, you are going to reduce the mortality significantly. They reduce the mortality of percentage that honestly I don't see in Italy, but according to their experience, you can decrease even of 70%, you know, which is so important. And so I think that we should sensibilize all the Western countries to really build up networks also for cardiogenic shock. Do you currently unload any MI patient prior to PCI? No, I don't unload any MI patient, also because for Italy, this is not according to the instruction for use of the device. The patient that I unload, apart from the patient that are in cardiogenic shock, or the patient that I showed to you. So the patient that I showed to you was a very high risk non-ST elevation MI with cardiac arrest. The patient had 3 vessel disease less than 35% of ejection fraction. So this is a patient that was needing Impella on board, or clearly patient with cardiogenic shock, or that is the indication that we are using in my hospital if there is a patient with an LVF less than 40 and large anterior MI. And in this patient, we do unloading before PCI.
But I think Rob is asking this in a STEMI situation, if you have a large anterior wall MI and clinically appears in cardiogenic shock, what is sort of, you know, your approach? I can say like what we do here is, you know, obviously there are multiple reasons why, you know, we would act in a particular way. There's obviously, you know, metrics of door to balloon that people are trying to achieve. You know, obviously some of them don't apply in cardiogenic shock, but right when the patient comes, you know, the clinical picture is not very clear often, and there's a bit of a rush to PCI. So I think he's asking more, you know, whether do you do any unloading ever in primary PCI for a
no? I mean, if it's not a large anterior MI, not honestly.
If it is
a large anterior MI and it's not in the D2 trial, only if LVF is less than 40.
Right. And so what is your device
LVF
choice?
Is another level, because normally our patients do an echo as soon as they get in the emergency room.
Got it.
So and they don't go directly to the cath lab. Normally they go into the emergency room and then in the lab. So we have the time to do echo. We look to the echo, and the patient that had the LVF less than 40, and I have to say are also patients you are going to invest, because that's another important point. We do have also a limit of age that I know that you don't use in US, but in Italy, if you are more than 80, honestly, unless there are exceptions, we don't use an Impella in this indication. So indication for us is apart for cardiogenic shock and MI complicated with cardiogenic shock is large MI with LVF less than 40 and less 80 over age.
In the sort of the intermediate category, are you using balloon pumps at all, or is your practice just either nothing or Impella?
So intraorgan pump I'm using only in old patients, as I said, more than 80. Or if they have issues with vascular access. In all the other indication, not. Unfortunately, the trial were negative. We had the class 3 indication since before the new guidelines. Now they go to strange 2C, whatever, but you don't have any data supporting. So unless it's an old patient, and you know, and we are not investing in Impella, only, or you have really bad access and you don't have the time for the transaxillary, or you are in the middle of the night and whatever, unless that, we don't use intra-aortic balloon pump.
Right. Yusuf has a comment. Great talk. I agree that IABP should not be used for cardiogenic shock or acute MI in the absence of mechanical complications. I also think that the role of IABP in high-risk PCI is limited. We should note that while in the BCIS-1 trial, high-risk PCI was neutral, in the primary endpoint analysis, the long-term follow-up did show significantly reduced all-cause mortality with IABP, which is true. And I'll also point out that in BCIS-1, they sort of compared all IABP, like, versus selective IABP. So there was about 10 to 15% patients who in the non-IABP arm did receive IABP as well, because, for whatever clinical reasons. So obviously these trials are really difficult to conduct and really difficult to dice out. And it almost seems like we need some sort of, the data to evolve and more trials to come in and eventually transform into some sort of decision aid, which can really help the physician, at the point of care to be able to decide whether mechanical support is needed and which device to use.
So I agree absolutely for the comment. The point is that the trial was neutral, so was not positive. So the concept, and this is why there was that indication, in case of a neutral trial, we did not feel comfortable to indicate a device that, however, is an adjunctive cost and can, however, expose the patient to device-related complication. I agree it's a 7 French, but it's a 7 French bifemoral, and normally we do primary PCI by radial access, and we know that radial versus femoral has a decrease in mortality. So this is why we did not indicate. And regarding the long-term follow-up, I agree. This is a signal, but this was not an endpoint that was pre-specified, and it's not the primary endpoint. So if the primary endpoint failed to demonstrate superiority, any other endpoints clearly should not be taken into account. That's why the group felt comfortable to come up with that indication. But again, this depends on the local condition and the judge of the physician, because this can be indication, but then each case is different. And for example, if you are, because that's also what we have to face. I mean, maybe not US or maybe not Italy, because we have also good DRG for these devices. So apart from that limitation from age, really to not make this cost exponentially. However, we can use the devices, but there are countries where they cannot use this device. So we can accept, for example, that they use intra-aortic balloon pump. I mean, in the absence of anything else, and despite the lack of randomized clinical trial, you can accept the usage of intra-aortic balloon pump. So clearly these are indications, but has to be compared with the center and capability of the center and economical constraints.
Any questions? Anybody else?
So for example, how many of you on the case that I showed you at the beginning, what would have you done? That's my curiosity, because that's again in a gray zone. It's not, I mean, in some center they would have waited to have the patient awaken, because at the end he had the cardiac, out of hospital cardiac arrest. And so there is always a question mark on the neurological status. So how many of you would have stabilized the patient hemodynamically with Impella, wait to see if the patient awake, unless again it is unstable, wait to see the neurological status and then decide which kind of revascularization? I mean, for me, it's a question mark, and it would be interesting to know your approach.
So this patient you said was intubated after the arrest, and you did the PCI in that intubated situation.
Yes.
Is that right?
So the patient arrived with sinus rhythm. So he was reanimated, but out of hospital. So as you know, there is always the questioning how the patient is reanimated out of hospital. And unfortunately, on neurological status, only after you extubate the patient. Before, we cannot predict. So this was the situation. Patient young, 50, in good clinical condition, no comorbidities, arriving in emergency room with ST elevation, intubated out of hospital, and with LVF of 35% and large akinesia of anterior wall. So what do? You study the patient, you see it's a 3-vessel disease with quite complex unprotected left main. What do? I mean, because clearly this is a 3 vessel plus left main, that is still an indication for surgery.
I would agree. I think you revascularize percutaneously with the mechanical support and then give the patient the best chance and then wait to see the neurological recovery. I don't think I think surgery has a really limited role in patients who are that sick in cardiogenic shock with the ST elevation. And I think withholding revascularization to see neurological recovery in a young patient, I would prefer to sort of do everything we can and then give them the best chance and see. So I would agree with sort of revascularizing.
Okay, good. It would be interesting to have cardiac surgeon comment. You know, our cardiac surgeon turned down, honestly, because they are used to us, so they know that we could do the procedure, because that's another point. I think there is another question. We have been disappointed with CP in cases of non-ACS shock. Do you have a preference of ECMO or 5.5 in non-ACD shock?
CAD. I think Sam
SCS?
is probably referring to non-ACS, but you know, either ischemic cardiomyopathy or non-ischemic cardiomyopathy who are entering into sort of a shock situation. Is that what you're asking, Sam? I think he may be on the move, but he's asking about non-ACS shock. So a patient who has advanced ischemic cardiomyopathy or non-ischemic cardiomyopathy, what is your preference for MCS in this situation?
So
the bridge
honestly,
to patient, I'm guessing.
Yeah. Honestly, this can be also an indication for intra-aortic balloon pump if it's not a severe shock, as you know, because that's the only indication for intra-aortic balloon pump is mechanical complication or not acute coronary syndrome shock. In our center, we do both. We do both ECMO 5.5. I have to say that we have an escalation. So we tend, maybe we should start with the intra-aortic balloon pump if it's not a severe shock. And then, or with the Impella, and then escalate the Impella with the flow chart that I show you. And if it's really unstable and cardiac arrest, refractory cardiac arrest, at the end of all the scale, they are put in ECMO, otherwise they're not. And then we have also a very large program for VAD, by the way. So the other thing is to put on VAD, which is not percutaneous VAD, but surgical VAD waiting for transplantation. We have a very good series. So, I mean, I have to say that the hospital has a large experience for percutaneous, but also for VAD as a bridge to transplantation.
Right. It does reduce their candidacy on the list, though. So
I know.
You know, that is one reason why we sort of keep pushing the MCS till they receive transplant.
But in Italy, we have the problem that transplantation has a very long line. I mean, we are not a country that, I don't know why, I don't know if it's religious dependent, but transplants are quite rare to occur. So that's why maybe we are also using VAD, because our transplantation time is much, much longer.
Okay. Well, I don't see any other questions here in the chat box. So again, Dr. Chieffo, thank you so much for taking time out and speaking to us. This was really helpful for everyone on the call, I think. So thanks again, and hopefully we talk to you soon or see you at some conference or something.
Okay, thanks to you for the invitation and hope to see you soon in person. Bye.
Okay. Thank you. Bye-bye.